G'day, Dominic Barfield here, and this is the RVC Clinical Podcast. Thank you for listening. Thank you for subscribing on your smartphone or generic fruit-based device, and we're really grateful for you taking the time to download and listen to this RVC podcast. We don't ask for much in return, but we're incredibly grateful if you could pop to Apple Podcast, Acast, Spotify, wherever you listen to your podcast and leave us a review. Obviously, a 5-star review would be great, but we really appreciate a couple of moments of your time to be able to do that. So joining us today, sort of outside of the RVC sort of realm, but a very good friend of mine, which I'm very honoured to have a friend of mine, Associate Professor or Dr. Claire Sharp, who is at one of the ECC leads at the University of Murdoch and has probably been at the University of Murdoch, I'm going to say, for 10 years, I think.
That's right. Yeah, just over 10 years.
So an Australian grad going over to the States to do her ECC residency and then coming back to Murdoch and the home of snakes. And so we thought today, or I approached Claire to ask her to talk about snake envenomation, and quite a strange question, quite a strange idea potentially for a UK podcast. But I thought it's very interesting, snake envenomation, and although we don't necessarily see that sort of very commonly in the UK at all, we only have vipers and so our European adders, and they're very sort of geographically sort of based. I thought it'd be good to sort of expand where we are with snake envenomation across the globe, because we do have a global audience, and thought we'd have a chat about snake envenomation. So thank you very much, Claire, for joining the show.
Thanks for having me.
Oh, it's great. They like strong-armed you into it anyway. But maybe we could start with sort of how snake envenomation sort of presents with patients, Claire, if that's all right. So I imagine there's sort of a couple of cohorts of patients that are presenting. So patients presenting when owners have said their dog or cat has been playing with a snake or have seen it sort of bite or concerned about that. And then there's other ones. I imagine no one has seen a bite before, and they sort of present. So maybe I could ask, with your experience, sort of, when do you think snakes are on the radar for the ones that no one has seen a snake envenomation?
Yeah, I suppose we are sort of lucky and unlucky in the envenomation syndromes that we see. The elapids that we have in Australia, most of them don't have locally acting cytotoxins, which means that often you don't find a bite site. There's no pain, redness, swelling, fang marks. And so you don't have that to go by, as opposed to the vipers, particularly some of the North American vipers that create this, amazing like local inflammation at the bite site and often local effects on coagulation. And so the dogs and cats just sort of ooze blood and interstitial fluid from the fang marks wherever they're unlucky enough to have been bitten. We don't have that clue very often. I was just looking at some data this morning with one of my graduate students doing a project on snake envenomation, and out of 50 dogs in this particular cohort that we were looking at, 5 of them had bite sites located, which is actually a lot more than I expected. Other studies show that maybe only 1% of envenomed dogs and cats in Australia have an identifiable bite site. So more often we're looking for other kinds of components of the envenomation syndrome. And many of our snakes, the most life-threatening component of envenomation is acute lower motor neuron signs. So, previously healthy, normal dogs and cats that 2 hours ago were walking and wagging are now ataxic and stumbling, or potentially even collapsed and tetraparetic, can't get up, is by far and away the most common presentation of envenomed animals in Australia. But there's also some other things in Australia that can look the same, and so we have to try and differentiate, particularly tick paralysis from snake envenomation if there's not an observed snake encounter.
So does that depend geographically of where you are in Australia? Because my crude understanding, although I have worked in Australia, lived there for a number of years, is that you don't have any tick paralysis where you are in Western Australia,
we
right?
Don't.
Or across the southern seaboard. You have to be in New South Wales or Northern Victoria?
Yeah, they used to say sort of within 25 kilometres of the east coast of Australia, and more the further north you go in Queensland. but really the whole east coast of Queensland, within proximity to the ocean, the whole east coast of New South Wales, and most of the east coast of Victoria as well. There are certainly published cases of tick paralysis in dogs that have never left Melbourne. So it's less common down there. It's cold and perhaps not as many ticks like to live down there, but there's still tick paralysis cases in Victoria. The only ones that we see in Western Australia are dogs or cats that bring a tick with them when they fly across the country. And usually we know because they've just gotten off a plane from Queensland and now they're paralysed.
Fair enough. That's why they probably shouldn't holiday in Queensland. No.
Exactly. Go to Bali instead.
So I suppose that's your sort of main differential, but most of the time, I suppose with tick paralysis, people are quite good at looking for ticks. They're normally or quite often still on the patient around the head and neck area, though can be anywhere in the ears, eyelids, vulva, wherever. But normally people identify them, right? And
vets are paranoid about them. So, the recommendations, there are some specific guidelines for the diagnosis and management of tick paralysis in Australia. And those guidelines basically say that if an animal presents with clinical signs that could be due to tick paralysis, to clip all the fur from the whole dog or cat and apply an acaricide and repeatedly search the whole animal because occasionally small ticks, will get stuck in ears and between toes, as you said. So the added sort of security blanket is a tick clip and tick searches and acaricide application. So it is fairly easy to rule in or rule out, but it's always on people's minds that maybe they've missed a tick.
So with those sort of presenting signs, Claire, then how do you work out, or is it important to work out what is the possible snake that has bitten said dog or cat?
Not necessarily. So the vast majority of snake envenomations in Australia are from tiger snakes or brown snakes, very original names. We were chatting a bit before the start of the podcast about how brown snakes and tiger snakes can each look like anything. So the names are not particularly helpful to identifying the snakes. But because those two snakes account for the overwhelming majority of envenomations of humans and pets, the antivenom that we have available has antibodies against both brown snake and tiger snake venom components. So it's a polyvalent antivenom. So it's actually really not important to differentiate between brown and tiger snakes. The much more important question is, does this animal have enough evidence that it could have been envenomed by a snake that it's worth giving antivenom to? So we don't even necessarily care about a definitive diagnosis. We care about the weight of the evidence that the clinical signs could be due to snake envenomation. I was going to say tick paralysis. Could be due to snake envenomation, and that we feel that we should give antivenom. And the actual snake species doesn't necessarily matter. Of course, the exceptions are if it's not one of those snakes, the antivenom may or may not cross-react with venom components of other species. So for some species like the black snakes, particularly red belly black snakes, which are quite common again along the east coast and also through Victoria and into South Australia, that venom components from those red belly black snakes is quite nicely neutralised by tiger brown antivenom. So again, the diagnosis doesn't matter, but you can tell because the envenomation syndrome is different. Red belly black snake envenomed patients can be paralysed, but they also tend to have local swelling and pain that can result in a wound from local tissue necrosis, and often have hemolysis that might result in anemia requiring transfusion.
So is that the only sort of antivenom that you have available to you is the brown and black, and that covers any sort of brown snake, black snakes, tiger snakes? Are there any other snakes to be concerned about where it won't work, or if you're worried about envenomation and you have that available, would you always give it?
I suppose if you're worried about envenomation and that's all that you have available, you probably would give it. Death adders require specific antivenom. There's not very good cross-neutralisation. Death adders have a fairly wide distribution in Australia, more so in drier areas, but they're very uncommonly associated with dog and cat envenomation, at least in the literature. And similarly, taipan envenomation up in the Northern Territory and the northwestern parts of Queensland, they see taipan envenomation, and that requires specific antivenom that covers the taipan venom components.
And so if you're in those areas that might have those snakes around, I suppose you'd probably be aware of that and maybe have that sort of available.
Either have it or have a relationship with the local nursing outpost or human hospital so that you can acquire some from them.
Could I actually ask, so how are the antivenoms made?
So at the moment, all of the commercially available antivenoms available in Australia for snake venom, different to tick antiserum, but for snake venom components, are made in horses. So healthy horses who get to hang out and spend most of their life in a paddock eating grass get administered subcutaneously venom from a variety of snakes. And the goal when those horses are hyperimmunized by serial injections of venom is that, for example, if the antivenom that is produced in those horses is ideally going to cover all of the brown snake variety in Australia, they'll take some venom from brown snakes in Queensland and some venom from brown snakes in New South Wales and some venom from brown snakes in Western Australia and inject that into the horses over a period of time such that they develop particularly IgG against the venom components. And then they harvest plasma from the horses, purify that plasma to make a somewhat purified whole IgG product is mostly what's available in Australia. And then that gets put in a bottle and sold as antivenom.
And is that the same antivenom that you or I would receive if we had a bite from a black or brown snake?
It is. Yeah, it is, exactly. There is a company that produces veterinary-only antivenom in Australia, but multiple companies produce antivenom that is used in humans and in dogs and cats. And the veterinary-only company and their product is safe to use in humans. It's just produced in horses like all the other antivenom. I just don't think they've pursued licensing for humans. Their goal was only ever to make a veterinary antivenom.
And so, I actually, from my time, I saw ticks as living in Sydney at the time, and never saw a snake envenomation. But so I suppose my question to you is, like, how do you know? First question would be: do you use snake identification kits? Because that is available, isn't it? But I know that there's quite a cost associated with that. And I suppose when do you think it's appropriate to use that?
Yeah, so most of the time we're basing a diagnosis of snake envenomation or a high index of suspicion enough to make us give antivenom based on history, clinical signs, and potentially some clinicopathologic abnormalities like prolonged clotting times or increased muscle enzymes on a biochemistry. And it's much less common that we would reach for an SVDK, both in part because you don't usually need any extra information, that history, clinical signs and clotting and muscle testing is usually enough. But as you mentioned, the SVDK or snake venom detection kit test is quite expensive. Depending on the practice, probably the client is charged anywhere between 500 and 800 Australian dollars, which almost buys you a vial of antivenom. So many veterinarians choose to spend money on an antivenom treatment trial before they do an SVDK. I tend to use an SVDK when I have a diagnostic conundrum. I started to mention before we recorded the podcast, but I'll say again, we had a cat a few years ago that presented with very vague clinical signs of not being well, had a wound on its elbow that had sustained like 5 days prior, but the wound was already starting to heal. And then shortly after it arrived in our hospital, had an episode of urinating in its litter tray, but the urine was just pure hemoglobinuria. The cat had no lower motor neuron signs, no tetraparesis like our snake envenomed animals normally do. And one of my residents came to ask me about the case, And we had an index of suspicion that it might be a snake envenomation when they told me where it was from, because it was from a very specific geographic location around our city. And so we did an SVDK in that patient and confirmed that it was a black snake envenomation, which is the only black snake envenomation that I've seen at Murdoch in 10 years. So for those weirder snake species that don't have a classic presentation and often have a delayed presentation, the SVDK can be helpful. I've also used it in the workup of cases. I did a locum in the Animal Emergency Service on the Gold Coast some years ago, and we had a dog presenting with lower motor neuron signs, where our sort of top differentials were snake envenomation, tick paralysis. I suppose botulism goes in that list, polyradiculoneuritis and myasthenia gravis. The dog didn't have any history or clinical signs other than the paralysis consistent with botulism, so I didn't think it was that. We couldn't find a tick. The vet who saw the dog before me had already given some tick anti-serum. I did an SVDK as part of the investigation, and the dog was negative, and then we sort of moved on with our diagnostic evaluation and did a neostigmine response test to see if we could rule it in or rule out myasthenia. The dog didn't respond to that. And then the vet, who was the primary vet on the case, gave some antivenom just in case it was a snake envenomation with a negative SVDK. So sometimes we use it in those kind of complex cases. And I think that dog in the end was probably an idiopathic polyradiculoneuritis. But that's a relatively rare disease in Australia compared to other parts of the world, particularly in southeast Queensland. And so we use that test as part of trying to work out that case, because common things occur commonly. And so you want to rule those in or out early.
And so can I also, when you're administering, say, antivenom, is there anything else you do sort of prior to that? Are you... say always, I'd imagine placing an IV catheter. Are you always giving fluids to these patients, like intravenous fluids? Is there any other sort of treatment that you give prior to giving any antivenom, or is the goal just to...
The goal is to get antivenom in as quickly as possible in most cases, so that we can bind any unbound venom and potentially some venom at the neuromuscular junction. Some of the venom effects at the neuromuscular junction are reversible. And so ideally, if they're not yet paralyzed such that they need to be on a ventilator, if you give antivenom early, you can prevent them from progressing down that path. So we usually place an IV, pull some bloods from that IV for whatever we want to do, and then just immediately give antivenom. And the quicker the patient is dying, the quicker the antivenom administration in my hands. And then I think about all the other things afterwards once I've started giving antivenom. If it's a tiger or a black snake, because those snakes can cause myelitis and the black snakes locally acting necrosis, those patients are often painful, so we might give them some opioid analgesia. Depending on how long we think the patient may need to stay in with us, maybe we would put them on intravenous fluids, those kinds of things. But really, antivenom is our absolute priority. And of course, intubate and ventilate them if they have respiratory paralysis.
And is there any concern of either acute or delayed hypersensitivity reactions to the antivenom?
I think there's more of a concern than the data suggests we should be concerned. So some years ago, Manu Bolla, as the primary author, and a group of us from around Australia published a fairly large study using a registry type recording of snake envenom dogs and cats around Australia with hundreds and hundreds of cases in it. And we found that the rate of adverse reactions to antivenom was about 3 or 4% in dogs and about 1 to 2% in cats, particularly acute hypersensitivity reactions. So really, really low rates of adverse effects. And although in that study we didn't actually report the statistics, some vets do pre-medicate with antihistamines, less commonly adrenaline or steroids. But I often just quote the crude little chi-square test that I did on the data that we reported in the paper, which shows that there was no difference in the rate of hypersensitivity reactions in the animals that were pre-medicated versus the ones that weren't. So super low rates. That study didn't really dig into why those patients might have had acute hypersensitivity reactions. My clinical experience is that most of the cases that have a hypersensitivity reaction have had antivenom before, because we have repeat offenders. Particularly Jack Russell Terriers tend to be repeat offenders. They're often the most common purebred dog in our snake envenomation studies. Dachshunds also feature quite highly on that list. And many cats will get repeatedly envenomated. So those animals, the first time they receive horse serum antivenom, usually they don't have a reaction, but on second and subsequent exposure, they can have a reaction. That could just be, facial urticaria and angioedema, maybe a vomit, but potentially could progress to anaphylactic shock. And I've certainly had some cases that by their second or third or fourth envenomation, where they're getting antivenom for the most recent snake that they've attacked, they actually need a continuous rate infusion of adrenaline at the same time as they're getting their antivenom, because they've been so sensitized to the horse proteins in the antivenom product. But that's really uncommon. It's just repeat offenders tend to be more problematic.
Thank you. That's great. And could I ask you about the amount of antivenom that you administer? Because
oh my goodness, you've opened a can of worms.
I know, because I know that a bite can be a dry bite, and it depends on the time of year, and it depends when the last time they bit, and all these sort of it's how I know there's lots of variability, but I suppose clinically, how do you make a decision when to give more? There you go.
Absolutely. So I think the answer to that should vary geographically, because the snakes that we're treating and the specific composition of the venom, even within a single snake species, varies. And so I always recommend to people that if you want to learn more about treating snakes in your area, go and find the veterinarian who, has most expertise in treating snake envenomation in your area and talk to them about it. Often, people take suggestions that, for example, I might almost always give multiple vials of antivenom to symptomatic cases as a suggestion that they need to do that as well for the snakes that they see in their part of the world, which is not an assessment that I can make, because I can only comment about the snakes that I treat. And in my area, we believe that a lot of the snake venom contains neurotoxins that act at the postsynaptic membrane at the neuromuscular junction, which are reversible with antivenom. And so what we often see in our hospital is that an animal comes in and is paralyzed, and we give them one vial of antivenom and they show some improvement in their degree of paralysis. And we usually then wait a while, maybe 30 minutes, maybe an hour. If you're more patient than me, maybe longer than an hour. And if we believe we've waited an adequate amount of time for that first dose of antivenom, first vial of antivenom to have its effects, and the patient is improved but not able to stand on its own and take a few steps or walk without collapsing, then I would give another vial of antivenom at that time and do the same. Observe the patient for 30 plus minutes after administration, see what degree of improvement that I get from that second vial of antivenom, and then decide again after that period of time if I'm going to give more. And what we'll often see is, a dog comes in and is peri-arrest, about to die from envenomation. They're totally paralyzed. We emergently intubate them, start giving antivenom, and with the first vial of antivenom, they might go from being unable to spontaneously ventilate. We've got them intubated, connected to an ambu bag and oxygen. They might be unable to spontaneously ventilate enough to manage their own CO2 removal. We give them a vial of antivenom, and maybe their spontaneous respiratory efforts improve. Like we may be able to see a little bit of chest excursion, but for example, they might still need us to provide some supplemental ventilation. We give a second vial, and then maybe they'll start, by an hour and a half or 2 hours into treatment, they'll start ventilating on their own, and so we can extubate them, but they might still remain paralysed and recumbent. And so then a little bit later, we give them a third vial, and after the third vial, they can stand and walk a little bit. And then we might call it a day and give them a little bit more time to see what happens. If sort of 4 hours later they can't stand up and walk across the room, then I might even give them another vial. As soon as you stop seeing improvement with subsequent vials, you should probably stop giving antivenom. And that theory that I'm going by works only for venom components where you can see rapid reversibility. In the eastern states of Australia, the theory and some scientific evidence to suggest is that more of the venom components act at the presynaptic membrane and cause irreversible neurotoxicity. And so some of those patients that require mechanical ventilation need to be ventilated for days, potentially regardless of whether or not you give them 1 vial or 5 vials of antivenom. So vets in Eastern Australia tend to dose antivenom a little bit differently. That being said, if a patient is severe enough to require intubation and ventilation, most veterinarians in Eastern Australia will give 2 vials of tiger brown antivenom. When we give less than that is a patient that has very mild clinical signs, we'll only usually give a vial, or a patient that may be asymptomatic at the time of presentation, but we have enough evidence that they've been envenomed. So maybe a dog found with a dead snake that comes in and we measure clotting times, and the clotting times are prolonged, which gives us evidence of venom-induced consumptive coagulopathy. Even if the dog is walking and wagging and happy, that would prompt us to give antivenom, but we'd probably get away with just a single vial in that case if there's no evidence of neurotoxicity at that time. So it's sort of dosed based on geography and severity of clinical signs and a little bit clinician preference because we don't have any data. In human medicine in Australia, it's also very controversial because there's a camp of physicians that believe that 1 vial of antivenom is always enough to neutralize the venom in a single bite. And I can't speak for human medicine because I've never treated a human for snake envenomation and I haven't read all of the literature. But we do know that many dogs have much higher venom concentrations in their bloodstream than humans envenomed by the same species of snake, probably because the Jack Russell is repeatedly attacking the snake and the poor snake is repeatedly striking the dog, as opposed to a human where it may just be that the human steps on the snake and gets a single injection of venom. So there is some biological plausibility that dogs and cats might need more antivenom than humans.
So can I just ask, Claire, when you said if you've got a dog that walks in that's been playing with a dead snake, so is your minimum thing if you're unsure to look at clotting times? Is that your what you say, okay, I'm not sure, that's the test that I'm going to do?
Yeah, for an asymptomatic patient, most of us reach for clotting times first, either APTT, an activated clotting time, or for hospitals, like ours that tend to do viscoelastic testing, we're mainly focusing on the clotting times on ROTEM or TEG. I suppose it's the R time on TEG. But the reality is that those viscoelastic tests are usually flatline if the animal's been envenomated anyway, because they don't just consume clotting factors, they consume fibrinogen. I suppose it's a clotting factor, but which with no fibrinogen, they can't make any semblance of a clot. So it's super useful in those cases that have no clinical signs at the time of presentation.
And can I ask as well, so you're talking about like a great way, like how animals might progress and you're giving more and more sort of vials. And is there a time that you're concerned about, I don't know, the lymphatics picking up more of that venom and animals to deteriorate? Or do you think that after, say, 12 hours, you're progressing one way, you're going to be fine?
A sort of delayed envenomation or re-envenomation syndrome because of a venom depot at the site of envenomation, I do believe happens. It's certainly well described in humans. Mike Shea has described a few cases in the US, I think, and I do think happens in our veterinary species as well, just not that commonly. So the only case that I can think of, I hope he won't mind me sharing it, is a case of a mutual friend of ours, Dr. Mark Kim, when he was treating an envenomed cat here in Western Australia during his residency. And it's the only case of a venom depot that I think really happened. So it was a cat that presented, it had the most mild weakness you've ever seen after envenomation. And he made a plan with the owner, given how mild the cat's clinical signs were. It had no increased muscle enzymes, no clotting abnormalities, that they would do watchful waiting with this cat. So the cat was admitted rather than just giving antivenom off the bat. I think it was an owner that was particularly concerned about antivenom adverse effects, even though, the data doesn't suggest that adverse effects are common. And I think it was something like 18 hours after presentation that the cat was fine, and then had a respiratory crisis and required intubation and ventilation, because obviously the venom had just hit its system, bound at the neuromuscular junction, and the cat became paralyzed. So of course the cat got antivenom at that period of time, was intubated and ventilated with an ambu bag for an hour or two until the antivenom did its job, and then was extubated and went home and lived happily ever after. So the goal, I suppose, of giving antivenom is to give to excess, so that you've given as more than is needed to neutralize the venom in the animal. So I think because we give antivenom to excess, we don't see those syndromes very commonly. But it's possible that if we were using different kinds of antivenom other than a whole IgG, which has a really long half-life in the body, if we were using an FAB type antivenom, which is essentially, half the size of an IgG molecule in terms of antigen binding sites, that product has a much shorter half-life. It's possible that the antivenom could be excreted from the body before the venom is excreted from the body. And certainly with those FAB type antivenoms in humans, re-envenomation is a big problem. And that has sort of led to those antivenoms going out of favour.
Enough. Well, thank you. That's incredibly thorough. And obviously, we live in the real world, and although obviously Australia is the idyllic part of the world, but the contextualized care has to sort of come in, because what you're talking about with the antivenom, it comes at a cost, right? And I suppose it's where are we at with, well, what do we do if we either don't have antivenom available for whatever reason? Is there anything that we can do, or even are you foolish to even consider trying that?
Yeah, so I suppose it depends on how severely envenomed the animal is. And for those patients that require intubation and ventilation, then they need antivenom and they won't survive without it. And maybe if you could ventilate them for days or weeks, but the reason you can't afford antivenom is because you can't afford that level of care. So I suppose a few options. We've been extremely fortunate in our hospital for a long time, since I was a veterinary student, that the human hospitals in Perth often will have antivenom that's gone out of date, that they will donate to veterinary hospitals. And so we have a stock of out-of-date antivenom that we use for owners that don't have the finances to pay for an in-date vial of antivenom. And actually, there's been some fascinating research by the World Health Organization looking at antivenoms up to 35 years old and looking at their neutralizing capacity. I saw a phenomenal presentation by a WHO scientist, and she tested the potency, the neutralizing capacity of more than 100 different types of antivenom from countries all over the world that were anywhere between just gone out of date and 35 years out of date. And the vast majority of those products, particularly for the first 10 years that they're out of date, maintain almost identical neutralizing potency to what they were marketed to have. So that's a good thing about whole IgG antivenom, is antibodies are really, really stable, and the products are produced in an aseptic fashion. They're in a sealed bottle, and so they're safe from the perspective of immunoglobulins are very stable when refrigerated, and they're still effective because the antigen binding sites of the immunoglobulin are still chemically intact. So I've saved numerous dogs with out-of-date antivenom. Multiple dogs that have come in paralyzed, required emergent intubation. I've, of course, had a discussion with their owner about using an out-of-date product and the theoretical risks that could come with it, and had owners, sign a form to say that they understand the risk that I'm explaining to them. And we've, intubated, hand ventilated with an ambu bag, given a few vials of out-of-date antivenom. The dogs have extubated and gone home within hours. Often the way that you save money in these cases is to give them antivenom early, particularly with the more reversible venom components, because then you might almost completely reverse the envenomation syndrome and they don't even need to stay in the hospital. In fact, I usually say in my hospital, I don't see most of the envenomed animals because they come in the evening. Our emergency vets that work in the evening treat them effectively and they're discharged by the time that I start at 7:30 in the morning. So expired antivenom works really well for that. I suppose not every hospital has expired antivenom available, and so they've got to think about other options. And the more mild envenomation cases, particularly in cats, may survive despite receiving a dose of venom. There are reports of cats that maybe have been recumbent for a week from paralysis from an elapid snake. And as long as their needs are taken care of in terms of they're kept, warm and dry, kept clean, they're given food and water, that works fine for those cases that can maintain sternal recumbence on their own and eat and drink. That I've managed or co-managed cases with no treatment that had a more milder envenomation syndrome. And some of the data that Manu and our group published some years ago did look at survival rates in animals that didn't receive antivenom, and it's about 50 to 60%, as opposed to about 95% with the cases that do receive antivenom. Of course, this is just a registry study, so probably the cases that didn't receive antivenom were the mild ones to begin with, but there was still about a 50% survival rate in those mild cases. So a few options to think about. If you don't have antivenom, there's nothing else other than time that's going to do that job for you, at least at this stage. There are new drugs on the horizon for snake envenomation that may work across snake species that are being developed for under-resourced countries, that those drugs could have application in humans. But for now, if you can't give antivenom, it's usually just supportive care and time.
Does Australia have more envenomations than North America? Do you know?
That's a great question. I can easily pull myself up a map. I have in the background of my computer a presentation that I gave at EVEC Congress last year, open, in case you ask me any curly questions about snakes in Europe, that I could at least have a resource in front of me. But I have a map in front of me that shows, at least in humans, in Oceania, so Australia and Papua New Guinea and New Zealand, there's between 3,000 and 5,000 human envenomations a year, with between 200 and 500 deaths. And in the United States and Canada, there's between 3,500 and 6,500 envenomations. So very similar number of total envenomations in North America, but only 7 to 15 deaths. So in Australia and Papua New Guinea, that Oceania region, we have a higher rate of fatality, but not a higher rate of envenomation. Where the numbers just skyrocket ridiculously is in Asia, particularly Southeast Asia and India, where there are millions of envenomations a year and tens of thousands of humans that die, probably up to about 100,000 human deaths a year in Asia as a result of snake envenomation.
That's quite a frightening number, isn't it?
Absolutely. Yeah.
But maybe I should ask you about European adders and treatment of that. I suppose that's probably a good question. I do get asked it occasionally, and there's normally on the south coast. There's pockets in the UK of places that see adder bites, and I believe you're probably the consistent finding would be there'd be Jack Russells, I'd imagine, or those sort of terrier breeds that always
Yeah.
get into scraps. But I suppose again, like is the use of antivenom in your understanding in the European adder situation as important as antivenom in elapid treatment?
I believe it is, certainly from the literature that I've read, from sort of around Europe, including places like Poland that I didn't even realize had snakes, until I started writing about snake envenomation and being asked to review papers from Poland. But yeah, I think it really is. And I think a little bit like North America, the European viper bites, perhaps traditionally, when we did our residencies sort of 15 plus years ago, a large number of veterinarians were not routinely recommending antivenom for all viper envenomations. I think we were scared of antivenom adverse effects, and we were told, the envenomation syndrome isn't that severe. They usually survive, but the morbidity of those patients in the interim can be very high. Certainly, they're prone to other organ dysfunctions, but the pain can also be really significant. And when you hear human snake envenomation victims talk about the pain from their viper bites and how they were given opioids, they were given acetaminophen, paracetamol, didn't touch the pain, and then the antivenom went in and they just felt this overwhelming relief. The pain was gone within minutes of antivenom administration. So I think even if it's for nothing more than analgesia in animals that have locally acting cytotoxins from the venom that have caused a swollen, painful bite site, we should be giving antivenom to those cases. And certainly it will also prevent the more life-threatening manifestations that can occur even with the common European vipers.
I think sometimes for us, Claire, it's that availability of it, and
Yeah.
I've looked into it from time to time. But I think actually one of the antivenoms that was available was manufactured in Poland, and I think it's always with like drug regulations how you get things imported into countries, etc.
Yeah.
But I think accessibility to it in a timely fashion is always going to be a challenge, I think. But maybe if we move over the other side of the pond into North America, is it mainly the crotalids that are the problem, and are there similar presentations or issues than the elapids that you've discussed?
Yeah, so I suppose North America has sort of a single elapid of note, which is the coral snake, and coral snake envenomation is particularly common in the south of the US and southeast especially. Those cases present fairly similarly to an eastern brown snake envenomation, for example, but the rest of the US absolutely is affected by viper envenomations, including the crotalids, as well as other genre like the copperheads and cottonmouth snakes. So their vipers, much like the European vipers, tend to have locally acting cytotoxins that cause a painful swollen bite site that bleeds and oozes, as well as hemolysins that cause characteristic changes to red cells like echinocytes that you can use to diagnose envenomation, but that could also lead to enough erythrocyte membrane injury that those patients may become anemic and potentially even require transfusion, as well as myelysins that again can be painful and cause muscle enzyme increases on blood tests. So fewer neurotoxins in North America and more hemolysins and locally acting cytotoxins.
Are they similarly geographically located? As I think we were discussing as well, like it's very important in Australia, like where you are, what the type of sort of snake is most common in that area. Is that
Yeah.
similar in North America as well? There's very regional.
Absolutely. Yeah. And usually when I go to snake envenomation conferences, like a total snake envenomation nerd, there's a few vets from a few pockets of the country. So there's the Florida crew, Dr. Shea and his sort of entourage of students and residents that he's taught over the decades. There's usually a group from Colorado where they see snakes quite commonly. There's a whole group of vets often that come from Arizona because they see Mojave rattlesnakes as well as copperheads and some of the more typical rattlesnakes. And also into sort of Southern California where they see, again, their own unique distribution of snakes and everything in between. There's sort of a gradient in between those centers. So absolutely geographic variation is key. And for anybody who's ever been to North America and been to conferences hearing people speak about envenomation, it's the same experts from each of those areas that have created a lot of the knowledge sharing in veterinary medicine in the US about the unique snake envenomation characteristics in their areas.
And I suppose to maybe go back to the beginning, I suppose if maybe you never know, sometimes that clients might listen to this. So I suppose if you're worried about your snake being envenomated or you're seeing it play with the snake, obviously the most important thing is not to go near the snake yourself. I imagine that some snake bites occur with people trying to get their pet off a snake or vice versa, and
Absolutely.
And never try and kill a snake. I think take a photo would be good. Lots of people can identify from photos. And I'd imagine that most areas have wires or an appropriate group that might, because sometimes the snake might be injured itself and might require
Exactly.
help itself. But I think wires
Absolutely.
are the main thing in Australia, aren't they? They're the
Yeah,
group that would
absolutely.
look after snakes.
Yeah, and some local areas may have a snake catcher come first, and then one of the wildlife groups would either take the snake if it's injured, or if the snake catcher deems the snake suitable for release, they'll just take the snake away from the suburbs and release it somewhere else. So it depends a little bit on the area and how injured the snake is. We don't tend to see a whole lot in between. Usually either the snake is has been killed, particularly by the dog, but sometimes by cats. Or the snake is usually not that injured, but occasionally we do see snakes that we sort of have to decide if, hopefully not me, but hopefully a wildlife person has to decide if the snake has injuries that can be recovered from the dog or cat. But absolutely, for the pet owner, don't touch the snake, don't try and catch the snake. And in our area, we don't even say photograph the snake if the snake is alive, because we're going to give the same antivenom regardless. We say ignore the snake and bring your dog or cat to us. There was just a recent, my friend and colleague Andrew Padula, who's like the snake man in veterinary medicine in Australia, he was just telling me on a research call this morning that there's a recent report of a person being fatally envenomed by a snake that was already dead. So you can't be careful enough. You just shouldn't touch snakes in the wild, and focus on getting your dog or cat to the vet and cared for as quickly as possible.
Is there anything? I know when I went to a little race in Morocco back in the day that we had to have, because they had vipers there, like a snake a pump, like almost like a little suction to remove sort of venom, which was quite interesting. Although I actually did see a snake on that run, but I didn't get bitten by it, thankfully. But is there anything about using something like that, or splinting, as in, are we worried about the lymphatics, or is it all just, what, like, yes, you can do things like that, but just get to a vet?
Exactly. I think it's a bit different between humans and animals. So for dogs and cats, we generally say keep them calm. If you find them in the backyard, for example, and it's a small enough dog or it's a cat, pick them up. If you can, immediately put them in a carrier. If they're used to being in a carrier, put them in the car and bring them in. So you basically minimize that animal moving around. but no attempts to tourniquet or splint or suck the venom out or anything like that. Of course, sucking the venom out isn't usually an option for us because you can't find the bite site anyway. But it's essentially impossible to immobilize a limb in a dog or cat at home, and tourniqueting can be unsafe in a dog or cat at home. So just minimizing stress, minimizing movement, and getting to the vet is really important. I've had a few owners, I think, save their pet's life when their pets were envenomed on a walk, and they picked their dog up and carried their dog, 2 kilometres back to the car to then come to the vet, because I do worry in cases like that, if the dog is walking 2 kilometres back to the car, that gives plenty of opportunity for venom to be picked up by the lymphatics into the circulation and circulate. So, if you have that option, trying to minimize your dog walking around. For humans, I think there is some evidence to suggest that immobilizing the limb is beneficial so as to minimize venom spread, but not for animals.
Thank you very much for that. Can I ask, obviously you're still heavily involved in sort of research to do with envenomation. Can I, one question is just sort of, why do you like envenomation? Why does it pique your professional interest?
I suppose for multiple reasons. I think one is that although the survival rates are very high, 95% in dogs and cats that get antivenom, that still means that 5 out of 100 previously healthy dogs and cats, were normal that morning, ate breakfast, happy, walking, wagging, purring. 5 in 100 of those cases that get envenomed will die from envenomation. So that is an area where I think that we can do better. Science can do better. That's one reason why I investigate it. And just that whole concept of a previously perfectly healthy animal, often they're young, being envenomated is just a really devastating thing. Like any kind of environmental emergency in vet med, it's a little bit easier, I think, sometimes to cope, when an animal's 15 and, gets cancer and dies. These are usually 2, 3, 4-year-old animals. And, I hate the thought that there's still animals that die from this syndrome. So that's one reason. And I think the other reason is that there's still so much that we have to do in terms of improving treatments. There's a lot of low-hanging fruit, for the last however many decades to humans and animals. We've just been giving whole IgG antivenom made in horses. It's a purified product, but it's still a very crude treatment. And in this day and age where we're using monoclonal antibodies for itchy dogs that are never going to die of their atopy, albeit, I know euthanasia is a thing for dogs with bad skin disease, we have the opportunity to develop novel antivenoms containing synthetic antibodies, for example, or developing small molecules that can reverse envenomation syndromes in animals and humans. So I think in modern science, there's a lot of opportunity for novel therapeutics that will really change the game for envenomated humans and animals. And it's really cool to learn more about those opportunities by collaborating widely with people from all over the globe that do this kind of research.
It is really fascinating. And I suppose that it's interesting that you've said that we're using this, envenomated horses to get your monoclonal antibodies. Maybe we can do better. But also, I believe that a lot of research is done into the venoms themselves to look for like new anticoagulants or the way that neuromuscular blocking agents work, etc. And so we're learning a lot from snakes in one way, but maybe we can learn to treat them better. I suppose I just wondered whether it was more your interest. I know another one of your big interest is coagulation, and whether that crossover you liked as well.
There's probably many things that I like. And I think I also like the community of people that are interested in snakes and snake envenomation. We've talked before about all the snake nerds, because I count you as one of them, that go to some of the snake envenomation conferences. There's a lot of people that are investigating venom components from snakes and spiders and scorpions and various sea creatures that produce venom as therapeutics, because there's so many opportunities to produce useful drugs. So yeah, I think having a group of equally nerdy people that I can talk to means that I always learn new things, and I'm just sort of perpetually amazed at the just endless amount of cool science that there is out there.
And just finally, Claire, and then so what do you think are going to be, say, in like 5 years' time? Do you think there is going to be a paradigm shift or new ways of treating snake envenomation? Do you think it's close, or are we talking more sort of 20 years, 30 years time?
No, I think it's close. We are in a process of clinical trials of novel therapeutics, both small molecules and novel antivenoms. Small molecules that inhibit snake venom components that are shared across vipers and elapids and all different genera of snakes. So molecules like verasplodib, which may help with paralysis from elapids, for example, or murimistat, which may help with hemotoxicity and locally acting cytotoxicity by inhibiting matrix metalloproteinases. So these small molecules could potentially be put into an oral medication that a person in the field in Africa or India who's envenomated while, tending to their farm can take a pill from their local health post that buys them time to get to somewhere where they can get antivenom, or potentially, if we get far enough with these drugs, won't need antivenom at all. Same for dogs. These drugs are being trialed in dogs. And the potential for antivenoms that have broad neutralizing antibodies that can neutralize, not just the venom from tiger and brown snakes in Australia, but the venom from all of the elapids all over Australia and Asia, or maybe all over the world. And so instead of each country producing their own antivenoms and some countries not having appropriate antivenom at all, these pan-specific antivenom products produced with modern monoclonal antibody type technology can just be sitting in a shelf-stable lyophilized product that sits there, and you add some saline to it and give it to your patient when you need it. So I think in 10 years' time, the world is going to be really different in terms of the way that we approach envenomation, and hopefully in the number of humans and animals that have better outcomes after envenomation.
Well, thank you so much, Claire. And do you think there's anything we didn't cover that we should?
No, I don't think so. We've talked about some of the plethora of snakes that are out there and how we diagnose envenomation, or at least have enough concern to administer antivenom if that's available to us, how we give antivenom, monitor antivenom, do that other supportive care, the breadth of envenomation syndromes, cool new stuff on the horizon. I think we've done pretty well.
Well, thank you so much for your time there, Claire. So we'll wrap it up there then, and many thanks to everyone for listening. So don't forget to hit that subscribe button on your generic fruit-based device, and that way you don't even have to worry about missing an episode. If you leave a 5-star review on Apple Podcasts, Spotify, Acast, wherever you get your podcasts, that would be great. Don't forget to tell your friends. We'll even accept herpetologists to this podcast. We'll place any show notes at the RVC pages. So just type in RVC Clinical Podcast into your search engine of choice. It should be top of the tree. If you have any comments or suggestions for this, you can get in touch. You can either email dbarfield@rvc.ac.uk or podcast@rvc.ac.uk. You can follow us and message us on Instagram at RVC Clinical Podcast. Until next time, bye-bye.